pregnancy period, during registration, after they have attended at least 4 ANC visitation, and also during delivery. So a total of 5,000 naira is given to each woman. Next. So because we understand that social cultural factors actually influence women's decision on maternal health care, and also ultimately their health-seeking behavior, we carry out some activities, community sensitization. We have the community outreach. Mama Base carry out community outreach to raise awareness on maternal health care. And also we have the community ANC for communities where there are indigent women, women who are less likely to utilize the facility for their ANC and delivery. So bringing the ANC close to them, they have access to a certified nurse from their PHC to build trusted relationship, after which we encourage them to use the facility for their ANC and delivery. So we also provide emergency support for women who are referred from the PHC to a secondary facility. During their early pregnancy, we support the cost of care for women with, through the Lagos State Health Insurance Scheme, that's the Ilera Eco, while for those who are referred to a secondary facility at the point of delivery due to complication, we support with a sum of 50,000 naira or as needed. So lastly, we conduct advocacy. Mama Base provide feedback from the community to the policymakers within Lagos State Health System and advocates for evidence-based changes and improvements. The data provided can also be used to utilize decision-making process. So during the Mama Base program, we were able to register 7,883 women. We have the largest number of women from Ikorodun, that's 969, and the lowest is from Ajeromi Felodun, where we have 201 women. So I will be handing over to Mr. Lekon to give more insight on our data. Thank you.
All right, thank you, Miriam. So I'm here to just give the Mama Base data. So my name is Olagunju Olalekon, data manager on Mama Base project. Just go to the, okay, next slide. So before I share the insight from the Mama Base project, let us run through the demographic of women that we registered. As you can see, for the age group, we can see that 25 to 29 age group is the most women that we register, and this reflecting the peak period of age, reproductive age group. Next slide, another. So for, with respect to marital status, we know that majority of them are married, and this is not supposed to be a surprising result for us. Next slide. But with respect to socioeconomic, and we ask them from the beginning to say that whether they are employed. By employment, we mean that whether they are getting something, like they have something, some activities they are doing that are giving them money. Then for level of education, next slide. Level of education, majority of them are secondary school holder. So let's go to the next slide. So the next slide, this is one of our objectives. From the beginning, when we ask them, when we want to register them, we ask them whether they've registered for antenatal care, and we can see that more than half of them, they've not registered for antenatal before. And if you look at it, we have reduced the number to 16%. And also, when we look at the number of people that will register for Mama ANC now, it has increased from 47% to 84%. Next slide. So, with respect to birth outcome, so we have a total number of 7,728 babies that we know that they have delivered, and 80% of these babies, they deliver them at health facility. And unfortunately, we recorded 9 maternal deaths. Also, we have 132 stillbirth and neonatal deaths. Next slide. So the next slide is just showing us the reason why our women need to patronize health facility. And if you look at the number of live births we recorded compared to number of neonatal death or stillbirth, you can see that for out of facility, we have higher number compared to those women that deliver at facility. So I will now pass it to Dr. Olubodun to wrap up this discussion. Thank you.
Good evening, everyone. I'm Dr. Sokwa Olubodu. I'm a consultant public health physician with MRH Research Collective. I'll be wrapping up this discussion by putting forward the evidence that supports that community-based interventions are important in increasing healthcare uptake and reducing maternal and neonatal mortality. Every day, about 800 women die from preventable causes related to maternal and childbirth. And Nigeria alone, we record 82,000 maternal deaths in 2020, which represents 28% of global maternal deaths. There are about 2.6 million stillbirths and 2.9 million neonatal deaths each year, and most of these occur in Africa and South Asia. We need an appropriate mix of interventions to significantly reduce maternal and perinatal mortality and morbidity. However, these interventions a lot of times don't reach those who need them the most, who are the poor and the vulnerable. Therefore, an integrated approach that does not only look at clinical interventions, but also health system strengthening interventions and very much community-based interventions is needed to reach the unreached. Briefly, I will talk about the evidence that supports community-based interventions by looking at a few studies that have used community-based interventions. Study 1 was a study done in rural Bangladesh to assess the effect of a participatory women's group on neonatal mortality. What are participatory women's groups? These are groups of women that come together to do 4 things: to identify and prioritize their health problems, to devise strategies to address these health problems. Then they now implement these strategies and evaluate the impact. At the end of this study, after 2.5 years, neonatal mortality rate was significantly reduced. This study was not only all about participatory women's groups, but they also had some health system strengthening components, which include training of health workers, provision of basic medical equipment, and strengthening referral linkages. There are some similarities between this study and the MRA Child Project. For example, we did the respectful maternity care training and the EMOC training for health workers, and the EALOGI project also does referral linkages. The second study was a study done in Mali by Kayento et al. To evaluate whether proactive home visits can improve ANC utilization. And in this study, community health extension workers visit homes to assess women for pregnancy. And the pregnant women are invited to the hospital for ANC, while those that are not pregnant are offered pre-conception counseling or family planning as needed. And this study found a 25% higher odds of 4 or more antenatal visits in the intervention group. We have similar findings in our MRA Child project. For example, the Mama Base recruits women for antenatal by deploying CHOOS and local government coordinators to communities to find these women and register them for ANC. The next study is a cluster randomized trial in southern Ethiopia by Yosef et al. To evaluate the effect of health education on maternal health service utilization. In this study, women were divided into groups and received several health education sessions, and there was an overall utilization increase of antenatal care, health facility delivery, and postnatal care. Our projects, both of them also have the health education component, in which over 9,000 women received health education across 35 communities. And we can see that it led to increase in utilization of health facility in those communities. This is the 4th study, and it is a cluster randomized trial in Kano, Katsina, and Kaduna states. And this study used a multiple intervention, which include community mobilization, TBA training, health worker training, referral linkages, and supply of essential medicines. And at endline, MMR, maternal mortality ratio, neonatal mortality rate, stillbirth rate, and perinatal mortality rates decreased significantly in the intervention groups. Similarly, our projects also utilize health worker training and community mobilization. This is the last study. It is a qualitative study in South Africa to explore user assessment of an mHealth project. And mHealth means mobile health. This study used SMS messages to send information to women regarding their health. And the findings showed that women were consistently positive about Mom Connect, attaching high value to the content of the messages and the medium in which they were delivered. Our projects, both of them also include mHealth sending text messages to women to increase demand for the health facility and also to dispel myths and misconceptions. In conclusion, evidence shows that community-based interventions can be effective in improving uptake of maternal health care services and improving maternal and child outcomes. Community-based interventions should be integrated with clinical and health system strengthening interventions in order to deliver services for the poorest and most vulnerable. Thank you. I would like to ask if there are any questions or contributions.
Please, just take your laptop. We want to thank MRH. We want to thank MRH for their wonderful presentation. Your message is clear. Community-based approach in strengthening the health system and making sure that maternal and health care services uptake using that approach. Your message is loud and clear. Thank you very much. VP1, please photograph with them, please, photograph with them, please. The next presentation is a SOGON presentation in conjunction with DOFLIC. And that will be the final presentation for today before the para, please. So who is stopping them now? Go ahead.
Please, SecGen, join them for the snap. Kindly join them for the snap. Ladies and gentlemen, time is fast spent. And in all honesty, I'm not sure we can take the parallel sessions today. Again, as we speak, it's past 6. It's about 6 o'clock. We still have a session with DocFlix, HPN, and SOGON. Progress and challenges of HPV vaccination. And the presenter is Professor Onyebuchi Azubike, or the other way around, Professor Azubike Onyebuchi. Are you the moderator? And the moderator is Dr. Maureen Umemo. Please come up to the high table. We will do that in 30 minutes because from 7, the variety night will start even before 7, so we can round up the day. Thank you.
Good evening, elders, professors, and colleagues. It's so nice to be here. It's a work of months that have come to reality. I would like to use this opportunity to thank Professor Jaland of Charité Germany Teaching Hospital that initiated this, that linked me to DocFlix, and also Dr. Rasaka that I met face-to-face before we started that. And also Navan and Shushan that came to West Africa for the first time yesterday. I have to tell them special welcome. And also our president, Professor Bazu, president of SOGON and Secretary General. When I got them, they were interested and were able to develop it to the stage we are today. So I'm quite grateful and I thank you for coming. As a word of introduction, because they're going to talk to us briefly, DocFlix is a global leading technology company